In this chapter, we're going to deal with one of my favorite topics with endocarditis, a disease where echocardiography really makes a big difference, as you will see. Well, endocarditis has actually been recognized for many, many centuries. The first reports go back to the year 1646, where a man called Riviere first described structures on the aortic valve which also seemed to obstruct the outflow of blood. But it took the work of many scientists such as Corvisart, Virchow, Pasteur, Koch and Netter to really describe and find out what the cause of endocarditis was, namely bacterial infection. It will be one of my key messages in this presentation to show you that it is very important to make the diagnosis as early as possible. Well, many in our hospital have recognized this and have realized that if we put endocarditis on the referral, then they would usually have a fast lane ticket to an echo. So what I usually do when I get these patients into our lab, before doing the echo, I look at them and I kind of try to guess, do they really have endocarditis? Yes or no? And surprisingly, very often I'm right. Nevertheless, echocardiography is the foremost way to diagnose it and not the clinical picture. But you need both. Nevertheless, the clinical picture is very important. And together with the echocardiographic finding and the microbiology, we can make the diagnosis of endocarditis being either possible, probable, or definite. So what speaks in favor of endocarditis from a clinical perspective? Fever and night sweats, and the presence of predisposing factors. We talked about these two issues already. The presence of regurgitation, another valvular destruction, and peripheral manifestations such as Janeway lesions, Roth spots, splinter hemorrhages, and conjunctival bleedings. From the echocardiographic perspective, it's the vegetations, remember, the hallmark of endocarditis, but not only vegetations. There's many other things that we can find in patients who have endocarditis, and we'll see many cases and many examples in this chapter. One word about the shape of vegetations. Well, I've seen all sorts of shapes. This is a fairly common type where we have a very narrow base. Usually those vegetations are very mobile. Then they can look like this, broad-based and not so mobile. Finally, we can have all sorts of bizarre shapes, grape-shaped or lobulated, or a combination of all different types of vegetations. And then finally, probably the most difficult type of vegetation to diagnose are those here, where we have a very flat vegetation on the valve. We see those, for example, in the setting of fungal infection. The third pillar for the diagnostics of endocarditis, following the clinics and the morphology with echo, is a positive blood culture. A positive blood culture for typical organisms such as Staphylococcus and Streptococcus. So, to make the diagnosis, you need the blood culture, you need the clinics, and you need the echocardiogram. To put all this together, a scheme has been proposed, the so-called Duke classification, which you will find in the fact sheets, which kind of gives you the likelihood for the diagnosis of endocarditis. Still, I think even more important is that you learn how variable endocarditis can be. Therefore, I'm going to show you several case examples, both of patients who have endocarditis and patients who do not have endocarditis. Here are some typical findings of fresh endocarditis. Endocarditis of the aortic valve. We see the typical motion of an aortic valve vegetation. Here we have a vegetation on the anterior leaflet in a mitral valve endocarditis. A very large vegetation on the tricuspid valve in the setting of tricuspid valve endocarditis. And here, a very rare finding, actually the only image I could find of a pulmonary valve endocarditis. I'm quite sure none of you would miss the diagnosis in these cases. But it's not always that easy. Well, what about these patients? Do they have endocarditis? Well, here we have a structure on the aortic valve which looks very similar to the previous cases. However, this was an aortic valve fibroma. And here we have a structure on the posterior leaflet. A vegetation? No, this is part of a papillary muscle in the setting of papillary muscle rupture. And this small structure here, which also appears to be mobile and seems to look like endocarditis, was not endocarditis, but just a ruptured aberrant chordal string. And on the aortic valve in this patient, we have string-like structures. What are they? No endocarditis. Those are Lambel's ecrescences. Here are some more examples. Again, my question to you, endocarditis, yes or no? This is a patient with a calcified mitral valve ring. Does he have endocarditis? Well, no. This was just annular calcification. But I have seen patients where we did have infection within such a mass which was calcified. Here on the top right, you have to look very closely to see that there is thickening of the mitral valve. But does the patient have typical endocarditis? No, certainly not bacterial endocarditis, but he has the typical finding of endocarditis in the setting of Lippmann-Sachs. And here on the bottom left, what about this patient? Does he have endocarditis? Should he be operated? Well, probably nobody would operate because it's not a human, it's a dog. And he does not have endocarditis either. It's a large malignant tumor. And here on the bottom right, what about this patient? We have a very thick aortic root. Is there some form of aortic root infiltration? No. The patient just received a normal homograft. So you can see endocarditis is not always that easy to diagnose, and there are several different differential diagnoses that you have to consider. And here is a list. Fibrosis and calcification. We saw an example already. Myxomatous degeneration of the mitral valve, in other words, classic mitral valve prolapse. Tangential imaging of structures, which can sometimes really mimic a vegetation. Therefore, you have to use multiple views to make the diagnosis of a vegetation. Strands, we'll talk later what they are. Old vegetations, in other words, a patient who already had endocarditis, but who is now without infection and in a healing process. And finally, all sorts of tumors. For example, a fibroelastoma here on the aortic valve. One thing I almost forgot to mention with respect to the mitral valve. It is very difficult to make the diagnosis of endocarditis in the setting of a myxomatous mitral valve. I think I mentioned that already in the chapter on the mitral valve. Here we have a special situation. First, myxomatous mitral valves are thick. Therefore, they can look very similar to vegetations. Second, patients who have myxomatous valves have a higher likelihood of developing endocarditis in the first place. So there's a higher predisposition. And third, such patients also have a higher likelihood of developing a flail leaflet, which could look very similar to a vegetation. So the mobile structure that we see on a myxomatous mitral valve could either be just a simple flail leaflet, it could be a vegetation, or it could be both. In other words, a ruptured chordal structure caused by endocarditis. At least this was the case in this patient here, and the finding was confirmed during operation. But if we are capable of establishing the diagnosis of endocarditis with the help of the three diagnostic pillars, then echocardiography can also give us clues as to whether the vegetation and the endocarditis is fresh or old. The typical criteria for fresh vegetations are a more soft appearance. If they are more fibrotic and calcified, we can assume that the vegetation is at least several weeks old. Here on the right is an example which shows just that. A fairly echogenic structure on the aortic valve in a patient who had no signs of infection anymore, but who had endocarditis for several weeks. And here on the left, this is a patient who came with a peracute endocarditis, a drug addict who had both mitral valve and aortic valve endocarditis, you can see that there's a structure also located here on the anterior leaflet in the intervalvular fibrosa, and we have a completely destructed aortic valve. The aortic valve has simply melted away with the infection. But note the rather jelly-like and soft appearance of the vegetation. One of the biggest dangers in echocardiographic diagnostics is that we always tend to focus on the most prominent pathology, for example, the vegetation, and that we then forget about the remaining part of the heart. This can be detrimental because, especially in endocarditis, other things play an equally important role. For example, the other valves. Not infrequently do we have multivalvular infection, and this information is of particular interest, especially if we plan to operate. Also look at regurgitation. The severity can be an indication for surgery. For volume overload, again, as an indicator for the severity of regurgitation. And finally, look at left and right ventricular function, because patients who are in sepsis often show deterioration of right ventricular function. Here's a nice example of a patient who has endocarditis. Probably not fresh endocarditis anymore, but even without using color Doppler, you can appreciate that the patient must have significant aortic regurgitation. The left ventricle is dilated and hyperdynamic. And finally, one last example, what else you can see in the setting of endocarditis? A pericardial effusion. Why can patients develop pericardial effusion? Simply because some patients have pancarditis. In other words, also involvement of the myocardium and the pericardium. Here's a beautiful example where you can see the pericardial effusion here, behind the posterolateral wall, and also anterior. And here is the large vegetation on the aortic valve. And here is an actual patient. We'll now take a look at patient again and assess him with respect to the mass that we see here in the region of the posterior mitral valve leaflet. Well, to make the story short, he had endocarditis approximately 10 years ago, and what he now has, he has a residual calcification and a mass which is located here in the region of the posterior leaflet. So this is a typical finding that we see in patients who had endocarditis, that we have leaflet thickening and partial leaflet destruction, and especially calcification of the region where endocarditis was present. So you can nicely see that endocarditis was located on the posterior leaflet. The valve itself is also influenced by the endocarditis or by this mass. If we look at the color Doppler, we see that the valve is incompetent, that there is some degree of regurgitation, but since the patient is completely asymptomatic and ventricular function is still normal, there is no reason to operate him at this point in time. Now, one thing which is important to know, if we do not have the information that the patient is afebrile and that it does not have any signs of infection, this could also be active endocarditis. We do see patients with very similar masses who had endocarditis maybe or ongoing endocarditis for weeks or even months, and that within such a mass we still have active infectious material. So in summary, here is a patient with the sequels of endocarditis of the mitral valve. The examples you saw in this chapter only represent the small portions of cases that we have in our database. So don't forget to go into the atlas to see more. We're not yet done with endocarditis. The next chapter will deal with complications of native valve endocarditis.